Why is
I'll
that?
let you in on this conversation. So,
Yeah.
Aaron Bright is giving me a hard time. It's like I don't know good props.
Yeah.
All right?
That's what I'm saying.
That's what he's saying. He said that.
Yeah, I
What's
said.
not funny about a giant box of M&Ms?
Well, I'll tell you
What?
what's not.
What?
What is
What
funny?
is not funny
What
about
is
this?
funny about
You
a giant
reach
box?
in and you're like, I'm so hungry.
Well, that part is funny.
I'm so...
But you know how you do the one where you put the Coke can like this and you do that like, Diet Coke. I love it. It's for people that like Diet Coke.
You don't understand humor.
Yeah, that's what I was like. That's probably it.
Want to do some board review, boys?
I would like to do some board review. Mel Herbert.
You want to do some board review, ladies?
Oh, he's talking to you guys over there.
Yes. Yeah. Let's do a little board review. It's time. It's time to do a little board review. Cardiovascular section.
Yeah.
Huge, big,
Yeah.
enormous, large.
Show
Dunkakian.
me the slide of that cardiovascular. Do you have a slide of that?
I have.
Do you have like an intro slide? Oh, there it is.
There it is.
Oh.
Oh, was that a question about somebody switching? I wouldn't take that if I were you.
I wouldn't. I've
Oh,
stormed
just because the two of
stormed
you
the
get
tower.
to stand there and talk, don't make fun of the rest of us who have 150 buttons to push.
Oh, that's how it's
It's all
going to be.
coming out.
ladies
It's all
and
coming
gentlemen.
out.
That's how it's going to be.
Excuse me, why isn't this working?
That's right. Get ready for 2 to 3 hours of just angry cardiovascular review.
Welcome to Passive Aggressive Board Review with Mel and Aaron.
Yes. All right, cardiovascular.
Passive about our
It's nothing. It's just aggressive. All right, cardiovascular section on the exam is about 10 to 15%. Now, here's my word of advice to you. Most of you know the cardiovascular stuff really well because you do it all day. So listen to this once is probably enough for many of you. There might be certain subsections you need to go over, but if you really want to get good scores on the exam, probably spend more time on things like tox and derm, stuff that you don't do a lot of.
More like
But
that.
you've got to cover cardiovascular because, it is a big part of the exam. Now, having said that, look at all these things that we're supposed to cover. We're supposed to cover all of this. If you really did this in detail, it would be 40 hours just on cardiovascular. We don't have 40 hours.
Let's do it. 40 hours. Come
No,
on.
not 40.
Please?
No.
I'm going to try and
All right,
highlight
never
the
mind.
most important segments. Now, on the site, you'll be able to go into deeper dives where you wish, but let's just try and sort of do the big concepts and the stuff I think is most likely on exam. First of all, acute coronary syndrome. Here's the concept. It's very important. You got a plaque because you ate too many cheeseburgers and you got all fat, and that plaque is in your
talking to
vessel.
me?
I'm looking at you.
Oh.
And it ruptures. That rupture sort of tears the endothelium. That endothelium, when exposed, makes platelets and fibrin come in and stick on that. Boom! That reduces blood flow. If it's complete or fairly complete, then you get down the line cell death. You get death of myocardial cells. That's a myocardial infarction. If you're just having ischemia, you're having the pain, it hurts, but you don't have cell death, then that's called unstable angina. The big differentiator, a simple way of thinking between this acute coronary syndrome MI versus no MI is positive troponin. Positive troponin suggests cell death.
Yep.
Negative troponin suggests no cell death. Now, it's gotten very complicated over the years because the troponins are more and more sensitive. So stuff we used to think was unstable angina turns out to be positive troponin. But that's the basic concept. Cell death, myocardial infarction. Non-cell death, angina if it's chronic. Unstable angina if it's acute. We'll go into it. That's the most important concept that you sort of see here again. So the actual diagnosis of myocardial infarction is based on history, troponins, EKGs, autopsy studies. But in the end, it's about cell death versus no cell death. Does that really matter to you, Aaron?
It matters to me in that it categorizes my information, but it doesn't matter really.
Most of the time, it probably doesn't matter, except in subtypes, what we care about is what therapy do I give to this patient.
Yep.
So there are certain subtypes of acute coronary syndrome that really matter, and one of them is EKG changes. ST segment elevation is the big one. ST segment elevation, acute coronary syndrome, thrombolytic candidate potentially. No ST segment elevation, acute coronary syndrome, no thrombolysis. That is the big differentiator. Another thing you'll hear about, and this is again just a quick concept, transmural myocardial infarction tends to be big vessels, and you get infarction all the way through the muscle wall, and you have ST segment elevation, so a STEMI, ST segment elevation MI. These people, again, may benefit from thrombolytics. It just turns out magically that without ST segment elevation, we really haven't found subgroups where they benefit from thrombolysis. They may also, obviously, benefit from PCI. So ST segment elevation, thrombolysis, PCI. No ST segment elevation, non-STEMI, usually smaller vessels, usually subendocardial.
Subendocardial.
don't benefit from thrombolytics, plus minus benefit from PCI.
Yeah.
So that's the key thing. No ST segment elevation, no thrombolysis, except under one circumstance, handsome. And what is it?
Circumstance. I'm glad you got my name right. That circumstance is posterior MI.
Posterior MI. So you
V1,
can have
V2.
ST segment depression in V1, V2, V3 maybe. And that is actually ST segment elevation if you put the leads around the back.
Yep.
So if you see ST segment depression anteriorly, in somebody who sounds like they have ischemia, do posterior leads. If you see ST segment elevation, that is actually a posterior MI and an indication for thrombolysis. Is
That's
that
an
correct,
important
Tom?
That is probably correct, yes.
Excellent.
As far as Tom knows, that's correct.
Example question. And
Oh,
it's
good.
for Aaron. Let's check him out. Let's get the sweat on his brow. 50-year-old person. They got chest pain, diaphoresis, they're diabetic, they have ST segment depression, no ST segment elevation. The question I have for you,
Yes.
would you thrombolyze this person? Would you give him PCI, assuming it's not a posterior MI? Would you or would you not, Mr. Bright and Mr. Herbert? Would you do this?
Let's talk about it. I don't think I would thrombolyze this person. Mel, what would you do?
Well, ST segment depression, no thrombolytics. I agree with you there. But the question is about PCI.
Yeah.
Usually PCI is, you treat it the same way as thrombolytics. So if there's ST segment elevation and they've got no contraindications, I would use PCI.
PCI and thrombolytics tied together.
Tied together.
Yeah.
If you had this person and they're really sick and you know thrombolytics isn't going to work, you might have more patients try PCI because it doesn't have the side effects. What the hell is going past us
Son
right
of
now?
a...
What
You
kind of
got
a
the
studio
hovercraft?
are you running here? It's crazy.
Tuesday
bitch.
is trash day.
So PCI, same indications as thrombolytics, less complications so you can extend it out a bit, but there's all this stuff that's not for the exams, ladies and gentlemen, boys and girls, about in which patients PCI really works. If you don't have ST segment elevation, then there's all this stuff about non-ST segment elevation MIs, PCI doesn't work, but that's not for the exams. For the exams, think of it simply. Thrombolytics and PCI must have ST segment elevation, all right?
Or depression in V1, V2 for posterior.
Yes. So let's go back
Great
to...
talking to you, Mel. Let's talk to Mel over
Let's
here.
talk to Mel.
Let's
Let's
make sure that
continue on, Mel. You're doing a great job. Other causes of acute coronary syndrome, of course.
Yeah.
We all know this. Plaque rupture is most of the time. I made up a number. 95%. I just made that
Did
up.
you make that up?
But don't put that on the exam. I don't know
Yeah.
if it's true.
Don't tell anybody.
But that's the vast majority. But you can have inflammation, say a connective tissue disease, lupus, or rheumatoid arthritis produces inflammation that can damage the wall, and you can get plaques. You can get a trauma and vessel damage. For example, if I stab you through the coronary artery, that could produce an MI. Clotting disorders, you're just really hypercoagulable. Dissection, this is increasingly recognized. So you have some disease within the wall of the vessel, it dissects, and then you get clots, so you can have an acute coronary syndrome from that. Drugs.
What an incredibly unhelpful image you have there of a...
That's ACS. That's the City of Antonio Animal Services.
Yeah, good for you.
Yeah,
Sorry,
it's
go
good.
on.
Drugs can do it. You like what Tom does a lot on the weekends, just a big whack of cocaine. You can get a huge amount of spasm and clotting, and you can have an acute coronary syndrome from cocaine as well, Tom. So just settle down, you know,
Well,
pace
easy.
yourself.
How acute are we talking?
Tom
Yeah.
be clubbing. Tom be clubbing.
I'm a raver.
Then when you talk about unstable angina, again, this is a concept piece. I don't know if they're going to ask you this kind of question, but it's important. If you have chest pain every time you walk 10 blocks and you've got a narrow coronary artery, you have chronic stable angina. And that's not your disease. That's a disease for the internist to try and make you walk 20 blocks. When angina turns unstable is if you start to get pain at rest, or if it's new chest pain that you think is angina that started less than 2 weeks ago. If it's increasing in severity, I walked 10 blocks and now I can only walk 8 blocks and then 6 blocks and then 5 blocks. Something is going on there. Or if you have this chest pain and you have associated hemodynamic changes. Every time I get the chest pain, I get dizzy because my blood pressure drops.
Yeah.
So these are the things that make angina unstable, some of these things. So it's new and it's getting worse and it's at rest and its hemodynamic changes is unstable angina. There's also a subset that I really like on exams that you need to think about called Prince-Metal's angina.
Yep.
Prince-Metal's angina is coronary spasm. And it's classically white women in the middle of the night. So white woman, middle of the night, chest pain comes to the emergency department. And if you catch them early, they have ST segment elevation. You give them a nitro and it completely goes away.
Yep, I've seen that.
So it's spasm.
Crazy.
Most of the time, it's actually probably spasm over a plaque. So you don't send them home and say, you're fine. You say, it's Prince-Metal angina. It's probably over a plaque. You should still see a cardiologist.
I like that.
So don't be fooled.
They love that. That's a
Prince-Metal's
testable one. I don't know why.
yeah, I don't know. And then there's about a third of these patients, usually white women, classically, that are spasming and there's no plaque there and they don't know why. And they tend to treat them with calcium channel blockers and stuff. It's just an interesting disorder that you'll often see on the exam. So the classic thing will be, it'll be a woman and she'll have chest pain, and they'll show an EKG with ST segment elevation, and then they'll say 5 minutes later, it's completely normal. What's the diagnosis?
Right.
Prince-Metal's angina. But I would still admit. All right, let's talk about the EKG. The EKG in acute coronary syndrome is obviously very important in your clinical practice. It predicts the complications. It determines the eligibility for thrombolysis. We said no ST segment elevation, no thrombolysis. It predicts the vessel involved, and that's important because it can tell you some of the likely complications you might get. It's really important to do EKGs serially. So whether it's on the exams or in life, one EKG is not enough. Doing them serially increases the sensitivity and the specificity for the diagnosis of acute coronary syndromes.
See.
So here are the classic EKG changes in acute myocardial infarction, right?
Yep.
So there's ST segment elevation. So if I clamp your coronary artery right now,
Yeah.
it'll hurt.
Don't do that.
So I'm going to go through your chest wall, it's going to hurt.
Yeah.
I clamp it, you get ST segment elevation. That occurs within minutes to hours.
Yeah.
Hyperacute T waves is an early sign. So you get these big peak T waves from ischemia. That occurs early. Most of the time in the emergency department, we don't see that because unless you're having an MI on shift, by the time you get to the ER, it's an hour later. ST segment depression is very common. It can be from the ischemia itself, usually subendocardial, or it can be a reciprocal change to a transmural myocardial infarction. So you've got big ST segment elevation in one segment of your EKG and ST segment depression, which is sort of this mirroring of the ischemia elsewhere. Q waves are usually late, but don't be fooled. Even though they usually classically are late, 12 hours after the onset of MI, big, huge MIs often will develop Q waves within an hour. So don't be fooled just because the EKG shows Q waves that it's old. Although, you know, on exams, Q waves tend to suggest that it's old.
Right.
Don't be fooled if the history says this person with crushing retrosternal chest pain, and don't say it's old. Now, you also need to know that people who rule in for myocardial infarction by troponins or by autopsy can have a normal or near normal EKG in about 5% of cases, and much more early on. So the earlier on, lots of normal or near normal EKGs, and then over time it tends to change. But still about 5% of people who rule in have completely normal EKGs, which is a little disturbing. All right, let's draw some ST segment elevation. So this is going to be ST segment elevation. So you have your P, your Q, your R, S, T, wave, P. So the J point is this puppy here, and it's defined as, oh, that's a nice color. It's defined as the change in direction. So when it changes directions, that's called your J point. That's where most people measure ST segment elevation to the baseline, which is the TP baseline. So this is the TP baseline. So you go like here, and you measure your ST segment elevation right at that J point. Some people do J plus 1 millimeter and all this other stuff, but most people right at the J point. So let's say it's 3 millimeters of ST segment elevation. In the right clinical setting, crushing retrosternal chest pain, patient looks bad, it suggests MI. But there are actually many other causes like pericarditis and benign early repole and lots of other causes. But in the case of MI, where it clinically looks like an MI and they have ST segment elevation, this is an indication for thrombolysis, so thrombolytics. It is transmural. They get thrombolytics. They may be candidates for PCI. Remember that thrombolytics have lots of other contraindications, but this is the key point. J point here is elevated. In the right clinical circumstance, suggests MI. Now, you must go and do the TABIS EKG section on HIP-OEM. It is outstanding, and it gives you a huge amount of useful information about these other causes of ST segment elevation and how to differentiate. I thought that was excellent work, Mel. Thank you. The
Especially.
penmanship was
I
great.
tell you what.
I do want to emphasize that TABIS EKG segment. I'm just going to go through a few very quick EKG things here, but do the TABIS section, do the AMOMA2 section. The TABIS section for a quick overview. It's quick, it's a couple of hours. And then the AMOMA2 one goes into much more detail. So let's go from ST segment elevation. I think the next one we're going to do is ST segment depression and then T-waves. You ready for more animations? Are you excited?
Oh my goodness.
Roll the video tape.
Roll the tape.
Is it actually tape? Are you using tape over there?
Yeah.
I have some tape. Yeah.
This is on.
It's Scotch tape. Does that work for you guys?
No,
Tom.
not so much.
Scotch
Here we
tape.
go.
It's digital Scotch tape.
So let me try and do ST segment depression. This is hard for me to draw this stuff. As you can tell, not a great line drawer. So here we go. P. And then we're going to go like this. I'm going to come down, and then we're going to do one of these puppies. So in this case, you've got your ST segment, or your J point, is sort of here, that change of direction. Your baseline again is the TP segment, so it comes like this way. So you've got some ST segment depression, but it's down sloping like this, and then it goes into that T wave, the rest of the T wave, and then off to the Ps. You can also have it, and let's see if I can do this, P, QRS, down like this, back to the baseline. Here you have an upsloping ST segment depression. Again, if this is your J point is sort of down here somewhere, then you've got ST segment depression here, but it's an upsloping. And then there's one called horizontal, just down, flat back up. So this is planar flat ST segment depression. So ST segment depression comes in different forms. In the Tabor section, it'll describe which form produces, is most predictive of ischemia. But ST segment depression in the face of somebody with ischemic symptoms suggests that they've got ischemia. In this case, they don't get thrombolytics, so no thrombo for this group. That's one of the key things for the exam. No thrombolytics for ST segment depression, even if they have positive tropes, except in the one circumstance, V1 through sort of V3, ST segment depression could equal ST segment elevation in the posterior wall. So you've got to do posterior leads. All right, so ST segment depression, lots of different forms, suggests ischemia if the history is right. Not an indication for thrombolytics, except if it's in V1 through V3, because they might be having a posterior MI with ST segment elevation, so you do posterior leads. But again, go to the TABIS section for more info. You want to talk about T waves?
I do.
Yes, I like T waves. They're named
Cool.
after
Figures?
me
T?
because I'm T.
Let's go. Boom. Not much on T waves. So T waves. The only thing I want to say about T waves right here, real quick, is just this concept of the hyperacute T wave. So this looks like a normal T wave. Hyperacute T wave classically is going to look peaked and high, so higher and maybe even more sort of peaked like this. So hyperacute T waves occur really early. So early is the key. So within minutes of your ischemia, when you clamp a artery on a dog, you get these early, so they can also go away early. So you only tend to see these in the emergency department in somebody who's having acute ischemia right now, not somebody who had ischemia that started 3 hours ago. So that's all you need to know there. Again, watch the TABIS section. All right, questions?
I'm done, bro. No.
Too bad.
Stab me in the eyes.
I've
No?
got more. Let's do another one. So let's animate this bad boy up, shall we? So here is an anatomical model which we're holding up, and we'll go through some of the important features here of the anatomy. So let's start with this then. And what you have coming down here, obviously, is your LAD, right? So your LAD is the big vessel that comes down the front here, supplies the anterior wall, which is here, and sort of the septum and anterior wall. So septum is in here, and then the anterior wall, you could say, is like all of this stuff here. So that LAD supplies that giant thing here. So V1 through about V4 is your LAD. You infarct that, you're obviously in big trouble because this giant piece of myocardium is dead. And if that giant piece of myocardium is dead, you're dead. So you get things like CHF, and you blow out valves, and you have lots of arrhythmias. So V1 through V4, very bad, widowmaker, to the cath lab PCI very quickly. Thing here. So over here is your circumflex. It's a branch off the LAD. So now this bad boy is going to supply over here, which is the lateral portion of your heart. Very important. It's still got lots of contractility and good things that it does. And so the leads that this correspond to is, can you think about it? 1, AVL, V5, V6. So you see these with ST segment elevation. Then it suggests that you're taking out your lateral wall, that it's probably, as we see over here, circumflex lesion, right? Now, what is this vessel over here? What is this bad boy? That is the right coronary artery, right? So it's right coronary artery. So it wraps around here, and it supplies, see, so it wraps around here, and it supplies down inferiorly, whoa, I've moved it around, inferiorly and posteriorly, all right? So the right coronary then, what does this right coronary supply? It supplies the right side of the heart and the inferior wall. So we're going to flip this heart over in a second, and you're going to see the circulation as it looks posteriorly. So actually, why don't we do that now?
Boing.
So let's animate this bad. Oh, you douchebag. So let's animate this bad boy up, shall we? So here is this coronary supply. It supplies the right side of the heart and the inferior wall. So we're going to flip this heart over in a second, and you're going to see the circulation as it looks posteriorly. So actually, why don't we do that now? So now let's look at the posterior part of the heart and the circulation and its implications for what we're doing here. So let's first of all look at this vessel that's sort of sneaking over on this side. What is that vessel? Well, that vessel, ladies and gentlemen, boys and girls, is the circ again, circumflex, and it is supplying this lateral portion of the heart. All right, so we talked about that. But what is this vessel, ladies and gentlemen, boys and girls, sort of sneaking around over this side? And with all these little branches up in here. Here, and these vessels that come down. What is this? That's the right coronary, okay? So the right coronary artery supplies the posterior wall in here, big contractile portion. It can supply down here, my little pin thingy. It can supply this inferior wall, and also can supply the right ventricle. So that's the right coronary artery. So if you've got a pure inferior wall, so you've got one of these posterior descending arteries, it's called, posterior descending artery, a branch of the right coronary comes down, inferior wall, 2, 3, AVF. Okay, so we know that these people can get, hypotensive bradycardia because that vessel also might supply the AV node. You give them fluids, they do well. If you have a more proximal coronary artery lesion, now you're taking out this whole section over here, then those people are really fluid dependent. You've got to fill them up. And so what does a right coronary look like? What's the EKG findings? So it's an inferior wall. Plus, if you do right ventricular leads, you'll see ST segment elevation in V4, for example. And posterior wall. Remember the posterior wall is here. This is the posterior wall in here. And where do you look at that on the EKG? You look at V1 through about V3. Now it's actually, that's the anterior part, right? So it's sort of reversed. So the ST segment elevation you'd have with an anterior MI is actually ST segment depression because we're looking through the heart backwards, as it were. All right, so remember, inferior wall down here, 2-3 AVF. Right ventricular infarcts occur from proximal right coronary artery lesions. So you look for an inferior infarct over here, and then you do your right ventricular leads. Posterior infarct, again, can be from a right coronary. And so V1 through V3, but sort of reciprocal ST segment depression in the anterior leads. The anatomy of people's coronary vessels can be different. So it is variable. You just need to remember that. They go to the cath lab, they look at their anatomy, they think it's a right coronary. It turns out to be a dominant circumflex and all that kind of stuff. But that gives you some idea of where the coronary arteries supply, where the EKGs are involved, and what some of the complications might be from each of those.
I'd love to have a question. Do you have any questions for me?
I got a question for you.
I'd
Okay,
like to have some
so
questions.
a patient presents with chest pain, and they have the following EKG. Which artery is involved? Now, this would be a really silly question because you are not a cardiologist and you don't care.
I don't.
But we'll ask the question anyway, just for learning. So, what do you think, Tom? Tom is our director here. Is not medically trained. ST segment elevation, V1, V2, all the way through V5. Which vessel do you think it is, Tom, having never done anatomy?
I think it's C, LAD.
LAD. You are smarter than the average hamster. So this is a big lesion, lots of ventricle involved. This is the widowmaker. This is left ventricle and septum, and it's bad. And this type of question, I think, is becoming less and less common. More likely they'd say, what do you do with this person? Is this a thrombolytic candidate? Is it a thrombolytic candidate, Aaron?
It sure is.
Yes. Is it a PCI candidate?
It sure is.
Thank you very much. Without contraindications, absolutely.
Mm-hmm.